Good evening. My name's Tim Coates. I'm Professor of Emergency Medicine in Leicester and Chair of Trauma Care, hosting this Trauma Care webinar this evening. It's absolutely brilliant to see so many of you on a wild and windy night outside. If you want to just pop your name, what you do and where you're from into the chat, then everybody can see who's here. The These webinars are only possible because we get sponsorship. It allows us to do everything at a very reasonable cost. We get our sponsorship from Slater and Gordon. They're heavily involved in rehabilitation of patients after trauma and getting the insurance industry together to provide very early rehabilitation for patients. They're interested in what we do, what we do here, and are our main sponsors. So many thanks to Slater and Gordon for this evening. There's the usual disclaimer is that stuff that you learn here is all accurate, but whatever we say here, you need to follow your own organization's policies and procedures and your own scope of practice. We may talk about things that are outside of your scope of practice. You need to stick to your own scope and your own organization. The presenters, I'm afraid we can't see and hear you. We'd love to be having a conversation, but we can't do that with 650 people now in the room. We've got two forms of communication. One is the chat that a lovely number of people are using so far to introduce themselves. The other is you'll see a button at the bottom called Q&A. And Q&A is the place to put any questions that you've got to the presenter, and then I can pull those questions together and ask them on your behalf. Questions in the chat, I tend to get a little bit lost in the chat that's going on amongst people. So if you put questions in Q&A chat in the chat, then it will. If you miss any of the vital facts, this entire webinar is recorded and will be available on our YouTube channel shortly. Got to do an advert here for the main event of the year in trauma management, which is the Yarnfield Conference. Special alert, the early bird registration is available until the end of January. So we've extended the early bird registration by popular request. March the 9th to 12th, go along to the website to look at all the good stuff that's going to be in multiple tracks over the conference at Yarnfield over those days. In particular, for this evening, there's a head injury stream, and here is some of the great content that's going to be in. So if you enjoy this evening's presentation and you want to know more, come along to Yarnfield and learn more about head injury management from the theme there with the fabulous Professor Mark Wilson, neurosurgeon from the Royal London, is coordinating the presentations there. The other great thing that you ought to do now is to become a trauma care member. For non-registered members of the trauma team, and for students it costs the same as a cup of coffee a month. For anyone who's got a registration, wants to be a full member, it's 2 cups of coffee a month, so less than a cup of coffee a week for all the great stuff that trauma care does. Just follow the QR code. Anyway, shall we get on to tonight's main event? Can I introduce Professor Fiona Lecky, who's Professor of Emergency Medicine at the University of Sheffield, has a special interest in trauma outcomes, and in particular head injury outcomes, and chaired the group that developed the NICE Head Injury Guidelines, and that's the topic of her talk for us this evening. So over to you, Fiona.
Okay, thank you very much, Tim. I'm just going to share my slides. Can you see that?
Not just yet.
Okay, let me try again. Just bear with me a second. It says someone else is sharing, so I'm going to replace current share. Share the screen. Okay.
That's now working with the slide sorter view.
Okay.
and you're getting lots of thumbs up from the audience.
Okay, perfect. Thank you very much. So, good evening, friends and colleagues. I'd like to echo Tim's thanks for being here on this snowy winter evening. I'm very grateful for the opportunity to speak to you on this excellent trauma care webinar about head injury guidelines from the National Institute for Health and Care Excellence. And I was the topic advisor for the last guideline update in NG 232 that was released in May 2023. NICE doesn't have specialist chairs anymore, but when they did, I chaired the update in 2014. So here are my declarations of interest. As Tim said, I hold a chair in Sheffield. I've put on here the recent and current grants that I hold as a TBI and head injury investigator. But I'd also like to point out to you, many of you are paramedics and clinicians here, that I am a consultant in emergency medicine at the emergency department in Salford Royal, work closely with our MWAS colleagues and at the Greater Manchester Major Trauma Hospital. So I have to apply these guidelines in my regular clinical practice, as does my team. Okay, we've got quite an ambitious agenda this evening. What I'd like to cover is why NICE Head Injury Guidelines exist and how they are generated, and then look at some of the recommendations and underpinning evidence in terms of who should come to hospital after head injury, what pre-hospital care should look like with some specific aspects around tranexamic acid, and care for people with head injury in the emergency department in terms of who needs a CT scan, who needs referral to specialist neurosurgery, and the use of blood biomarkers in patients with head injury. A couple of considerations around discharge and follow-up, including post-head injury hypopituitarism, and then the evidence that the guidelines have had an impact on patient outcomes. There is quite a lot of content. Please, as Tim said, put your questions in the Q&A. There's scope for me to break out of the slides and go into a conversation with Tim with your questions as well, so we can make it as interactive as necessary. Okay, so why should we care about head injury and traumatic brain injury? Well, the world is very slowly waking up, but in the nick of time, to the neglected epidemic that is traumatic brain injury. We have a nice definition from David Menon that it's an alteration in brain function or other evidence of brain injury occurring as a result of an external force. It's the most common neurological emergency that you'll see in your department, affecting 60 million people every year, according to the recent Lancet Neurology commissioned issue led by Andrew Marrs. And I think that's basically a significant underestimate. About 9 months ago, the UK Acquired Brain Injury Forum, UKBIF, did an economic analysis and identified that a staggering 1 in 30 of the UK gross domestic product is spent on the consequences of acquired brain injury. That's not just TBI, it's stroke and brain tumours. And this is due to the direct healthcare costs, the lost economic productivity, and the tens of thousands, millions of pounds that are spent every year on well-being costs for patients, family and carers, because traumatic brain injury, as well as needing acute care, often results in lifelong disability and impairment. Road traffic collisions cause the majority of the disease burden in young people, and as we all know, falls in older people. We also know when we look at how people die who reach hospital alive after major trauma that traumatic brain injury causes most of the deaths. So in this series from Tarn, the largest European trauma registry of 10,000 trauma deaths, 41% of the deaths occurred solely as a result of traumatic brain injury. Another 19% occurred with traumatic brain injury in the context of polytrauma. So if we don't get care right for head injury and traumatic brain injury, we're not going to get our trauma care right, full stop. Perhaps the best way to talk about the rationale and the impact of the NICE Head Injury Guidelines is to take you back to a time when they didn't exist. And it does very much feel like a long time ago in a galaxy far, far away. But in fact, it was only 22 years ago in the UK National Health Service. And I was still a consultant in the emergency department then. And we couldn't get a CT scan on a head injury patient unless their GCS was less than 13. In the NHS at that time, specialist neurosurgical and neuroscience care was only available to 2/3 of people with severe traumatic brain injury. And every injured patient was brought by ambulance to the nearest emergency department, regardless of that department's ability to care for people with a significant brain injury. We define head injury as any trauma to the head, excepting superficial injuries to the face. And when we looked at the frequency of this in the recent NICE Head Injury Guideline, we found that the 670,000 of all ages come to the emergency department every year with head injury as the chief complaint. And there are tens, possibly hundreds of thousands more where head injury is part of the clinical picture, but not the chief complaint. So about 1 million people coming to NHS emergency departments every year with head injury, which is not quite the same as traumatic brain injury. And what we really are worried about is the life-threatening injuries that we might see on CT scan. So just how common are potentially life-threatening or life-changing injuries on a CT brain scan in this population of 1 million attending our emergency departments every year? We looked at this on the Trauma Audit and Research Network with the Society of British Neurosurgeons, and on the TARN database, we looked at 15 months worth of data. This is about 10 years ago, but I still think it's pretty representative. And we identified 16,000 patients with life-threatening injuries or life-changing injuries on CT scan on the TARN database. So that's 1,000 patients a month out of the 100,000 or so that are coming to emergency departments. So what we're trying to identify is a veritable needle in a haystack. About 1 to 5% of all our head injury attenders coming to the emergency department will have positive CT scans. Of course, it's important to bear in mind that you can have a traumatic brain injury without a positive CT scan. So on this graphic, they're the grey patients who have a TBI but a negative CT scan. So as I say, this is a needle in a haystack that we're trying to look for. And when I go back to 2003 and what the approach was, most patients present with a Glasgow Coma Scale of 13 to 15, so full or nearly full consciousness. And our elders and betters at that time in the Royal College of Surgeons in England said that a CT scan was not necessary for this population, that you could manage traumatic brain injury in these patients by skull X-ray and observation. So the indications for a skull X-ray are on the left-hand side of your screen. Loss of consciousness or amnesia with GCS 13 to 15, focal neurology, signs of a complex or basal skull fracture, intoxication or difficulty in assessment. And the numbers by those numbers 1 to 6 at the end, those percentages are the percentage of 405 patients from the University College Hospital that was published in the EMJ in the 1990s. You could admit patients to hospital for GCS 13 to 15 if you had concerns, according to, again, this guidance from the Royal College of Surgeons of England, a history of loss of consciousness but no skull fracture, persisting neurology, difficulty in assessment, nobody to observe at home, patients on warfarin, and you could perhaps get a CT scan if there was a skull fracture. So we're all applying this guidance, and most of the time it worked, but sometimes it didn't. And here's a very sad example of me applying this guidance when I was a young doctor in the 1990s at Booth Hall Hospital. And we were put on standby for what at that time was the Greater Manchester Ambulance Service, put a standby call through for a 10-year-old boy who'd been playing with his friends on a derelict factory roof. He'd fallen through the roof and he'd lost consciousness. And on arrival, when he arrived in our resuscitation room, his Glasgow Coma Scale was 14. He was a bit disorientated, but his post-traumatic amnesia was rapidly resolving. There were no problems in the primary survey. His ABC was self-supporting, normal vital signs. He had a left periorbital hematoma, no focal neurology. And in the secondary survey, the only other injury was a displaced wrist fracture. I was able to speak to his friends and identify that he'd definitely lost consciousness at scene for 5 minutes. He wasn't vomiting. So I applied the guidance and did a skull X-ray, and he had no skull fracture. And then admitted him to the ward for observation overnight and a plan to manipulate his forearm fracture the following day. One of the reasons I remember this case very well is that I vehemently reassured his very concerned parents and grandparents that he was going to be absolutely fine. And I was applying the guidance to the best of the ability, which was based on consensus rather than evidence. Very sadly, this 10-year-old boy deteriorated overnight to a GCS of 8. He was brought to the resuscitation room, intubated. His CT brain scan showed an unsurvivable diffuse brain injury. And I don't know if there's any other practicing emergency physicians as old as I am. I'm sure Tim might remember similar cases, but most emergency physicians of my generation remember these awful talk and die cases with head injury and subsequently severe traumatic brain injury. So what happened to change all that? Well, two things happened. First of all, NICE came into being, the National Institute of Clinical Excellence, as it was called then. NICE is a guideline organisation. The first head injury guideline was CG4, the fourth one that NICE produced. Fast forward for 2023, and there are 218 different NICE guidelines, from everything from self-harming children to lung cancer. And NICE doesn't write medical textbooks, but it makes recommendations for areas of NHS clinical practice where the practice is variable, it's expensive, or there are safety concerns. And it's funded by the Department of Health, but is independent. It's a quango, an arm's length body. And the way that NICE works, and many of you might have been involved with the work of NICE, is for each guideline, NICE convenes a community of practice, including patients and the public, healthcare commissioners, clinical organisations and charities. And it develops a scope for each guideline with research questions. And then it convenes a multidisciplinary committee through competitive interview, including what are now non-specialist chairs. So for the last head injury guideline, we had Ian Bernstein, who was a GP, who was excellent. And the committee also consists of a technical team of information scientists who conduct systematic reviews, and health economists, and clinicians and patient and public representatives. And at the guideline committee meetings, we agree PICO search strategies, and the technical team go away and search the literature, conduct systematic reviews and health economic analysis, and they bring these back to the committee meetings, and we debate the findings and make recommendations based on that evidence. And recently in 2023, the French SFAR and SFMU, which is the Anaesthetic and Emergency Medicine Societies, developed a similar process for their mild traumatic brain injury guideline that was published in 2023. So these are the chapters of the NICE Head Injury Guideline, and they were first developed in 2003, other than investigating injuries to the cervical spine, which was added in 2007. And these have been, the chapters are pretty much the same now as they were in 2003. In 2023, these are the areas of the scope that we updated and conducted evidence reviews on. So we didn't update the whole guideline, just the areas that the scope indicated were necessary for an update. And one of the other things that NICE does when it's got a draft set of recommendations is it puts them back out to that community of practice, over 100 stakeholders, to say, look, these are the changes in care that we're recommending. What do you think about this? And we get a lot of feedback back. So on this occasion, there was a lot of feedback about advanced directives in terms of who needed to come to hospital after head injury. Obviously, the basis of our head injury assessment is the fantastic Glasgow Coma Scale. Where would we be, not just in head injury management, but the whole of emergency care without the GCS? And as I've indicated, prior to the first NICE Head Injury Guideline, we weren't able to get CT scans in people with a GCS of greater than 12. So NICE identified there was 3 potential strategies for people with head injury in a GCS of 13 to 15. You could CT none of them, which was our current practice at the time. You could CT them all, or you could CT a selected high-risk group. If you CT none, as was the practice at that time, you have 0% sensitivity for life-threatening injury and timely care, but 100% specificity, which means that the majority of people who don't have a brain injury don't have to wait around for a CT scan. You therefore have minimal cost, minimal radiation, minimal crowding in your emergency department of people waiting for a scan or for the result. If you CT everybody, the opposite is true. You have 100% sensitivity for all life-threatening injuries and timely life-saving care, but 0% specificity. You have maximal cost, maximal crowding, maximal exposure to radiation. Or you have an intermediate strategy of CTing a selected higher risk group. And the less selective it is, the more sensitive the strategy, the better opportunity for timely early care. But then you have more cost, more radiation, and more crowding in the emergency department. So where does the sweet spot lie? And this has to be the subject of a cost-benefit analysis, which is what the NICE clinical effectiveness and cost-effectiveness work is all about. Second thing that happened back in 2003, NICE was able to identify some fantastic research, the Canadian CT head rule from Ian Steele and colleagues in North America. And what they had done was look at 3,000 patients with head injury, GCS 13 to 15, and loss of consciousness or amnesia, and identify predictive and reproducible factors that definitely predicted who was going to need neurosurgical intervention. And these were not being back to a GCS of 15 within 2 hours of injury, any signs of open or depressed or basal skull fracture, vomiting more than once in these adults and age 65 years and older. And the medium risk factors were retrograde amnesia greater than 30 minutes and a dangerous mechanism of injury. So in the first guideline, the Canadian CT head rule was recommended for all adults and children. There was a big outcry back in 2004, not just from radiologists, but often from emergency physicians saying we can't possibly CT all these people. So we did a study in Salford and North Tyneside looking at exactly how feasible this was going to be. And we implemented the guideline with a few changes. So you can see on the top left of your screen, I'm trying to highlight this box with an arrow there, the high-risk features that Ian Steele identified in terms of not being back to GCS 15 within 2 hours of injury, open or depressed skull fracture, more than one episode of vomiting. And we also included people with post-traumatic seizures that had been excluded from Ian Steele's study because they were too high risk. And we called all those patients high risk in Salford, getting an immediate CT, and in North Tyneside. Ian Steele also identified older people as high risk, age 65 and over. And we CT'd them rapidly within an hour, between 9 in the morning and 10 at night when we had more radiographers. But because we had a shortage of radiographers overnight, if they were stable, and this was also true for people with coagulopathy, we treated them as medium risk in the same way we would treat people with loss of consciousness or amnesia with a dangerous mechanism or retrograde amnesia. And they would get a scan as a medium risk patient within 8 hours of injury. If there was loss of consciousness or amnesia with no other risk factors or no loss of consciousness or amnesia, there was no imaging required. What we found in this paper in these two centres is that the CT rate doubled at North Tyneside, doubled in Salford and quadrupled in North Tyneside. And so we were spending more money on CT scans, but we were spending less money on skull x-rays, which completely disappeared, and less money on admission. So we were saving money without compromising patient outcomes. So essentially, in terms of who needs to attend hospital after a head injury, and what NICE recommends for emergency medical services, including ambulance services and HEMS, is essentially the people that are going to need a CT scan after their head injury. So anybody who's not GCS 15, anybody with focal neurology, signs of a complex skull fracture, a persistent headache, vomiting, a seizure, history of coagulopathy or intoxication. And the French guidelines are very similar. But as I mentioned, in 2023, we got a lot of pushback from care homes about advanced directives. The very first recommendation in the guideline is if a patient in a care home has said they don't want to come to hospital under any circumstances and they've fallen and had a head injury, then they should obviously stay in their care home. So after 2004, the development was recognised, and I think people were very glad not to be doing skull x-rays anymore because they're essentially useless. They don't really tell you anything. And people started to use CT scans and they didn't need to admit as many people to hospital. But there was a lot of concern around children and this indication for imaging children after a single vomit because NICE was recommending the Canadian CT head rule to adults and children. So what we did to address this in the Northwest of England was a prospective study of 22,000 children attending paediatric emergency departments in the Northwest. And there were 270 children that had significant brain injuries. And we identified the risk factors for children for a significant intracranial injury. And this was done by Joel Dunning, who was a very bright PhD student. He's now a cardiothoracic surgeon in the Northeast. And Kevin McWay-Jones obtained the funding. And this is the Chalice rule, factors in the history, examination and mechanism which predict significant intracranial injury or brain injury in children, witness loss of consciousness, history of amnesia, drowsiness, more than 3 vomits, a suspicion of NAI, a history of seizure if they're not epileptic, an impaired GCS, signs of base of skull fracture, positive focal neurology, a large bruise greater than 5 centimetres in an infant, a high-speed road traffic collision or fall. And so these were recommended by NICE in the 2007 guideline CG56. And what NICE did was its full cost effectiveness analysis for an example of a 10-year-old child, such as the child that I'd seen, looking at the different CT strategies. So one of them would be CT none and discharge all, or CT all, as I've mentioned, and different clinical decision rules. And what NICE does is it looks at the costs of applying that guideline across 1,000 people and the average quality of life gains. So it looks at cost per quality adjusted life year, and it found the Chalice rule to be the most cost effective. And so that is what NICE recommended in 2007. Also in 2007, the NICE Head Injury Guideline, which at that time was chaired by David Yates, recognised that the cervical spine is very close to the brain and we need to think about how we image the cervical spine. And it recommended the excellent Canadian C-spine rule. And at that time, for adults on the left-hand side of the screen, if you were positive according to the Canadian C-spine rule, then you would get 3 plane views of the cervical spine. And the high-risk features were having an impaired GCS, being over 65, having a dangerous mechanism of injury or paresthesia in the limbs. And then were medium risk factors around having an absence of, the medium risk factors were not being able to move your neck if you're able to sit. And these are listed on the screen here. So we started off for adults with high or medium risk doing cervical spine x-rays. Over the years, we've come to recognise that cervical spine x-rays have a lot of limitations. They miss about 15% of significant injuries. And so now for adults in 2023, we're recommending that any adult who's positive in terms of high or medium risk indications on the Canadian C-spine rule should get a CT of their cervical spine. For children, we're more conservative. We started off again just recommending plain films for children who are positive according to the Canadian C-spine rules. Now we're recommending CT scans for children with a GCS of 12 or less, but still for children who are medium risk, we are still recommending 3 views of the cervical spine. And this is consistent with the NICE guideline for assessment of the spine. Moving on to other aspects of care in the emergency department, in 2007, NICE took into account this research from TARN, from the Trauma Audit and Research Network and the Society of British Neurosurgeons, looking at the outcomes of patients with severe traumatic brain injury. So these are people with positive scans who arrive intubated or with a GCS of 8 or less. And at that time, 1/3 of these patients were having care entirely outside of neuroscience care. They were all being referred to neurosurgery, but some of them were being refused because the neurosurgeons didn't feel an operation was necessary. And what this TARN research showed was this group who weren't getting specialist neuroscience care had double the risk-adjusted mortality of patients who were being transferred into specialist neuroscience care. So NICE made a recommendation in 2007 that neuroscience centres should agree arrangements where they can accept all these patients, even if they don't need a neurosurgical operation. Because what the research from TARN showed was that the mortality was still double, even for patients with diffuse brain injury, if they weren't cared for in terms of specialist neuroscience care. Moving on to 2014, and this is what the adult CT head guideline looks like now. One of the things that we did in 2014 is add a 3rd limb to the head injury CT scan algorithm. So we've got our high risk indications here, medium risk, who are back to GCS 15 within 2 hours of injury, but loss of conscious or amnesia, being older, coagulopathy or dangerous mechanism of injury or retrograde amnesia. In 2014, we also added, controversially, that even if you had no loss of conscious and amnesia, that you would still need a CT scan if you were taking warfarin. And this was controversial, but now in 2023, we've weakened that recommendation. So if there's no loss of conscious or amnesia, we're saying consider a CT scan rather than definitely do one. But we have extended this to clopidogrel and prasugrel because the evidence shows that they carry just as much risk as DOACs. So 2014, including warfarin without loss of consciousness or amnesia, but weakening the recommendation for all anticoagulants, extending it to antiplatelets to a shared decision-making consider rule. After 2007, we did some studies around adherence to the NICE Head Injury Guideline, what you would call implementation science. And what we noticed was looking at Salford Royal and the Royal Bolton, that adherence to the adult imaging guideline was very good, but it was poor adherence to the Chalice rule, and particularly poor where vomiting 3 or more times in children was the single indication. So in 2014, we took account of that and we modified the Chalice guideline. So for the high risk features in children, you would still get a scan within an hour. For the medium risk features, if you only had one, you would have a period of observation for 4 hours. And if there was still only one feature and you weren't on anticoagulants, you didn't need a CT scan. However, if you had 2 of these medium risk features, you'd still need a CT scan within an hour. If you don't have any of these high or medium risk features, if you're a child, you don't need a CT scan. And again, conducting implementation science, we saw that this was working very well for children, so we're not irradiating many children. This is a series that we did at Sheffield Children's back in 2015. We looked at about 4 months of paediatric head injury attenders before and after the third NICE Head Injury Guideline. And what you'll see is that almost 10% of children attending the emergency department do so as a result of injury. So a large percentage of our head injury attenders are children. And what you can see as well is that there's very few brain injuries in children. So this series of nearly 1,800 children, there were only 6 positive CT scans, and 4 of these were simple skull fractures. So brain injury is very rare in the paediatric head injury population. And we were able, using this modified Chalice guideline, to reduce the rate of CT scans from 4.8 to 2.4%. So this Chalice scan for imaging children means that it's safe. We're detecting brain injuries in children. The unfortunate 10-year-old that I couldn't look after properly in the 1990s would have had his injuries picked up early, but we're not irradiating the vast majority of children who attend emergency departments. So what about Salford Royal in 2023? As I indicated back in 2003, that the NICE Head Injury Guideline then increased CT imaging. We were doing about 30 or 40 scans a month as a result of that. In 2023, with Scott Beattie, one of our trauma leads, and Amira Rashid, a very bright trauma fellow from Malaysia, we looked at our practice in people aged 65 and older, because as most of you will know, this is the big growth area for head injury and traumatic brain injury. And we discovered to our horror that we're now doing 6 to 8 CT scans per day in people aged over 65 with head injury in a GCS 13 to 15. And 2/3 of them are taking a DOAC or aspirin. And about 10% of these scans are positive. So it's not a complete waste of imaging, but it's a huge imaging volume and contributes a lot to ED crowding. So recently I was asked to speak on USAM about whether we should order a CT scan to every elder coming with head trauma. And I think the best way to consider this is to think about a real patient. So this is a real patient that I saw recently, an 85-year-old lady. We were put on standby for her because she'd fallen with her friends going into the theatre, been knocked out for 5 minutes. Immediately, she was said to be unconscious by her friends. The paramedics picked her up. Initially, her GCS was 5. It rose to 14 at the scene, and it became 15 en route. And by the time I saw her, again, nothing in the primary survey. No other injuries apart from the head injury, but a definite history of loss of consciousness. And she wasn't taking pre-injury antithrombotics. So let's see what 3 sets of different guidelines say should happen with this lady. If you look at the French mild traumatic brain injury guidance, they think the highest risk for intracranial bleeding is if you're on anticoagulants or dual antiplatelet therapy. They would only scan this kind of patient aged 65 and over if they are taking anticoagulants or if they were on antiplatelet therapy. If their GCS is 15 and loss of consciousness or amnesia, she wouldn't necessarily need a CT scan according to the French guidance. Returning to our guidance, back to GCS 15 within 2 hours of injury, no high risk features, age 65 and over, we would always scan, I think, this kind of patient. And the NICE cost effectiveness analysis for people aged 75 and over has suggested this is a cost effective way of approaching these patients compared to the Scandinavian guideline. However, if you take into account Kirsten DeWitt's Canadian Falls rule, from her data, she's identified that the only older fallers that are safe not to have a head CT are the ones who haven't banged their head. So she didn't think that anybody who's older who had banged their head was safe to not do a CT scan. And her falls decision rule is that if an older faller didn't hit their head and they can remember their fall and there's no neurology and they're not frail, then they're the only group of patients where it's safe to not do a head CT. So for my patient, there's 3 different types of guideline advice. The French guideline saying she would only need a scan if she had anticoagulants or antiplatelets. NICE saying with loss of consciousness or amnesia, the anticoagulation status is irrelevant. And the Canadian guideline saying that regardless of loss of consciousness or amnesia, all older fallers who bang their head need a scan regardless of anticoagulation status. So what did I do? I applied the NICE guidance. We did a CT head scan and it was negative, and she went home with her friends. So this controversial area of scanning all these older fallers, I think one of the things we should bear in mind is this work from TAN, Society of British Neurosurgeons, as to what traumatic brain injury in the UK NHS actually looks like. So these are all these 16,000 patients who have positive head CT scans. On the x-axis here, we have the decades of life from children to the 90s and the proportion of all traumatic brain injury. And there's the different mechanisms of injury here. And you can see that traumatic brain injury in the 21st century is dominated by older fallers in their 70s, 80s and 90s. In fact, it's 60% of all traumatic brain injury. So if we're looking for a needle in a haystack, an older faller is a pretty good clue. The other thing to bear in mind is that the Glasgow Coma score is not as useful in older fallers who bang their head. And this is work from Tony Kehoe and Jason Smith, which has shown that for any severity of brain injury using the head AIS score here, head AIS 3, 4 or 5, the median or the mean Glasgow Coma score is 1 to 2 points higher in an older adult for the same severity of brain injury. So the Glasgow Coma scale drops much later in older people because of cerebral atrophy. So if bleeding or swelling occurs in the intracranial space after head injury, then it takes more time to drop the Glasgow Coma scale and raise intracranial pressure. Another reason for being cautious in older people is Karl Marinkowicz's PhD work. So we looked at 1,600 people with positive scans, GCS 13 to 15, who are admitted to hospital. And you might be surprised to learn that 1 in 4 of these people deteriorate if you define deterioration as dropping by 2 or more points in the Glasgow Coma scale, neurosurgery, seizure, ICU, or death. So 1 in 4 of these patients will deteriorate after admission from the emergency department. Of course, it is probably safe to send home people whose GCS is back to 15 in the emergency department with a positive scan if the injury is very small and they're not anticoagulated and there's no significant extracranial injuries. However, this is only about 6% or 1 in 20 of this population with positive scans and GCS 13 to 15. And I think there's other benefits for older adults in terms of CT scanning them with a GCS 13 to 15 after a head injury, particularly if they are on anticoagulants or antiplatelets. Because if the scan is positive and you can stop or reverse the anticoagulant or antiplatelet agent if the CT scan shows traumatic brain injury or skull fracture. But if the scan is negative, it's safe to continue that medication and let them go home. Once we know that there isn't intracranial pathology, but the older person has a lower GCS than normal, they have delirium, then you can more aggressively investigate cardiorespiratory compromise, intoxication, or infection as a cause of that delirium. And again, going back to our recent audit in Salford, what we found is it's not just the anticoagulant medication that's driving the CT scans in older adults, but 2/3 of them had another indication for a CT scan in terms of not being able to remember the incident and being amnesic for the incident. But of course, the amnesia might have been due to pre-injury dementia or other forms of cognitive impairment. So what about this new recommendation from NICE in 2023? Is this, it wasn't reducing CT scans in Salford, but is this shared decision-making actually possible? Or are all the older fallers who attend the emergency department, or all old people who attend the emergency department after head injury, so frail that they can't remember the incident anyway, and you're going to need to scan them anyway? Well, I don't think all of them are, but I think it's a small minority that you can use as shared decision making. So here's an example of a patient that I saw recently. A 76-year-old gentleman, fit and well, was doing some DIY at home and his drill had slipped and hit him on the left side of his temple. He had a small wound there, and I saw him as the front door clinician in my emergency department. He had no high-risk features according to the NICE guideline. He had no loss of conscious amnesia, and his only risk factor was the fact that he was taking pre-injury apixaban for stroke prophylaxis as he was in atrial fibrillation. Does he need a CT scan? So I was able to apply our new 2023 guidance and say to this gentleman, look, I think it's very unlikely you've got a brain injury. So our options are that you can wait for a scan and probably take about an hour. And I realised that it's probably quicker in Salford than a lot of other hospitals. And then you'll probably wait another hour for the result. Or you can go home and be observed by your wife and come back if you start to develop any of the worrying symptoms in terms of feeling sick, a headache, feeling drowsy, etc. And this gentleman was very happy to decline a CT scan, and he was discharged and didn't return to the emergency department. So yes, I do think that we do have a small population of fit older people, not so much the fallers, but other forms of head injury who are on anticoagulants with no loss of conscious or amnesia, where you don't need to do a CT, but you need to use shared decision making. So with this vast number of CT scans that we're doing, particularly in adults in the emergency department, can we use biomarkers, point of care biomarkers tests for gliofibrillary acidic protein and UCHL1 as made by Abbott to reduce the number of CT scans? Within the NICE guideline in 2023, we looked at this and we found that we couldn't say that it was clinically or cost effective, but we called for more research. And NIHR have now commissioned the BRAINS TBI study led by Virginia Newcomb in Cambridge to look at precisely this question, to randomise patients to biomarkers rather than a scan to see if we can reduce the number of scans safely without missing significant injuries. One of the unintended consequences of scanning all these older people is that it's essentially unmasked the silver trauma phenomenon. So this is some work I did with Tim and Dushi and other people on the TARN research committee. It's a slightly busy slide, but what this shows here is the first 20 years of the 21st century. And this lower purple line here is the proportion of the population of England and Wales that is over 75, which has remained relatively static over this time period. But the proportion on TARN with an ISS of 15 and over 75 has gone up from 10% to 40% over these first 20 years. And injured by low energy falls is now the commonest mechanism on TARN. And this is because of this red line, the proportion of people on TARN who've had a CT scan, and by and large, this is a CT head scan. So we're unmasking the brain injuries in older people, and this has driven the rise in silver trauma, also contributed to by better submissions to TARN. Moving on to other areas of pre-hospital care. In NICE 2023, we've recommended that patients who have head injury with a GCS of 12 or less, who you don't think have extracranial bleeding, you should consider giving them a 2-gram intravenous bolus of tranexamic acid within 2 hours of injury and an equivalent dose for children. This is different to the NICE trauma guideline, which is recommending 1 gram plus 1 gram for extracranial bleeding. And we took into account findings of CRASH 3 and the RAL pre-hospital trial. The RAL pre-hospital trial, many of you will know this, was a 3-arm randomized controlled trial. There was a 2-gram bolus for people with a GCS of 12 or less within 2 hours of injury who weren't shocked and weren't thought to have extracranial bleeding. And 40% of these people didn't have an injury on CT scan, they were intoxicated. Nevertheless, comparing the 2-gram bolus to placebo reduced all-cause mortality at 28 days by 28% and at 6 months by 20%, whereas the gram plus a gram bolus and 1 gram infusion did increase all-cause mortality. So this is the main reason why I've recommended a different regime for people with head injury without extracranial bleeding, GCS less than 13 within 2 hours of injury. And this is something that's particularly relevant in the pre-hospital environment. We did take CRASH 3 into account, which was using 1 gram plus 1 gram, but we didn't see that signal of a reduction of all-cause mortality in CRASH 3. Hence, we're recommending this different regime. I'm going to gallop through the next couple of slides because we're running a little bit short of time. I do want to leave time for questions, but suffice to say that NICE did its usual job of looking at clinical and cost effectiveness and did find that this intervention would be cost effective. It would save lives. It would increase the number of people with severe brain injury who would need rehabilitation. Nevertheless, we did consider that it would be cost effective. So it'd be interesting to learn and have any comments from you as to whether you're doing this in your own clinical practice now. But that's the recommendation again. And then if you go into the British National Formula, you will now see 2 recommendations for tranexamic acid in trauma. For extracranial bleeding, 1 gram plus 1 gram. And for suspected isolated intracranial bleeding with a GCS of 12 or less, 2 grams as soon as possible and within 2 hours of injury. Just to highlight from this slide as well that there's areas of clinical practice with TXA in trauma that NICE hasn't really made a recommendation on. So it's said pre-imaging, what if it's within 2 hours of injury for GCS 12 or less with suspected isolated cranial injury? You haven't given it before the scan, but it's still within 2 hours. Would you give a 2 gram IV bolus? It makes sense, of course you would. Between 2 and 3 hours is a grey area. The benefits of TXA are much less the later on that you get. You definitely wouldn't give it after 3 hours after injury. For suspected extracranial bleeding, there's a NICE guideline for 1 gram plus 1 gram. But what would you do if actually your pan-CT showed a brain injury rather than extracranial injury? I think what I would do within 2 hours is I would stop the gram infusion and I give another gram bolus. So just to highlight here that there's areas of clinical practice that are never going to be covered by the NICE guideline where you need to use clinical judgment. NICE also asks research questions where it's still asking the question about the safety of pre-hospital bypass for people in coma after head injury with an unprotected airway, and also about the timing of testing for hypopituitarism. Hypopituitarism is an important and often delayed consequence of head injury, as highlighted by Joanna Lane and the Lane Foundation. Any severity of head injury can result in post-head injury hypopituitarism, and it isn't always apparent soon after the injury. Joanna Lane started the Lane Foundation in memory of her son, who very sadly committed suicide and whose post-mortem showed undiagnosed post-head injury hypopituitarism. So we're advocating that people should suspect it in people who are admitted to hospital with traumatic brain injury, and also GPs should suspect it further down the line. Okay, so I just want to put up this slide as a summary of the NICE guideline recommendations that have impacted clinical practice over the years. So back in 2004, replacing skull X-ray and observation to diagnose brain injury in people with a GCS of 13 to 15. In 2007, bringing in the Chalice rule for children and imaging the cervical spine, and mandating specialist neuroscience care for severe traumatic brain injury. In 2014, suggesting that all patients with warfarin needed a scan, even with no loss of consciousness or amnesia, CT of the cervical spine for adults, periods of observation in terms of the Chalice rule to reduce the number of scans of the brain in children. In 2023, our 2 gram IV bolus for head injury with GCS less than 13 within 2 hours of injury, where there's no extracranial bleeding. Shared decision-making for CT in people who are anticoagulated, who are fit and well otherwise, and a CT for adults with all indications of suspected C-spine injury, and raising the awareness of hypopituitarism. So what difference has all this made to outcomes of patients? Gordon Fuller looked at this in terms of the specialist neuroscience care around the 2007 recommendation. And what you can see in this slide is the desirable blue and red bars for direct to specialist neuroscience or a transfer, and the undesirable green bar of care outside of specialist neuroscience care, reducing from 33 to 19%. And this halved case fatality from 2003 onwards in traumatic brain injury on the TARN database in a risk-adjusted analysis. Going back to Karl Marinkowicz's PhD work, looking at population-based trends in traumatic brain injury and what difference the NICE guidelines have made. So you've got 3 panels here. This is older adults. There was a secular trend here for increasing mortality as this population gets older and older. And the NICE guidelines haven't made a huge difference to that. We should bear in mind that these patients present with a high GCS and don't often present with severe traumatic brain injury. However, for younger adults aged 16 to 64, after the 2007 recommendation around specialist neuroscience care, a complete reversal of this trend of slightly increasing mortality to really reducing the population-based mortality for traumatic brain injury in younger adults. For children, there's been a secular trend of reducing TBI mortality that hasn't really been impacted by the guideline. And although most of you are listening from the United Kingdom, I think we have to remember our colleagues in low middle income countries who don't have access to CT scans in emergency departments or in the pre-hospital environment. And they're dealing with what we were dealing with in the UK in the 1980s of using cerebral angiography, the diagnosis of acute subdural hematoma, to guide neurosurgeons to make burr holds. And this is where you have neurosurgeons. So I think it's very much important for us to bear in mind that we're very privileged to have the facilities of CT scans in the NHS in the 21st century. So I just want to acknowledge the help of everybody on the guideline committees from NICE, the French guideline, all the TAN and emergency medicine researchers who've contributed to the work that I've mentioned. Are these guidelines or are they tramlines? It can feel like a tramlines cookbook rather than personalised medicine at times. An unintended consequence has been the rise of silver trauma, but I think that's a good thing. The guidelines do acknowledge uncertainty and where evidence doesn't exist. And just because there isn't a recommendation, it doesn't mean you can't do that in clinical practice. It just means there's no evidence. There's very few don'ts in the NICE guidelines, but one of the things it says is don't use skull x-rays, don't use tranexamic acid after 3 hours. Advanced directives and shared decision making are very important context. Not following the guidance does sometimes have medico-legal implications. So I'm aware of an emergency department that was successfully sued for not following the CT imaging guidance. And as I've shown you, they can make a difference to outcome and improve patient outcomes. And we need to think about how we can share our experience with colleagues in the Global South to make these facilities available to them. So that's all I had to say. I think there's a bit of time for questions. I will stop sharing. I don't mind going over time if people have got that time.
Okay, thank you very much indeed, Fiona. Absolutely great outline of where we've gone over the last 20 years. And yeah, the days of peering at skull x-rays and trying to work out whether something was a suture or a fracture, that seems like a very long time ago, but perhaps it is. Loads of questions here.
Okay.
Quite a lot of them focused on the this elderly, frail group of patients that is, really exercises us both in pre-hospital care and in the emergency department.
Yeah.
Particularly where there's quite a lot of patients there that can't do the shared care thing. And just questions, I guess, perhaps I can sum up several questions in one by saying, okay, there's an alternative strategy here that you could say, very frail patient, not going to be suitable for neurosurgery. So if they have a neurosurgical type bleed, that's going to be palliative care. Falls over a head injury in their care home. There's a strategy of actually, and they're on a DOAC, they've come back to baseline. They've got a bump on the head. There's a strategy which some of my colleagues are using, which is, okay, stop the DOAC for 3 days, because if you see a positive CT scan, that is the only thing that you might do. Stopping the DOAC on someone who's on it for AF has got very little risk to it. So rather than transport, follow the guideline and CT scan, in those cases, just stop the anticoagulation for a few days and observe the patient. If the patient deteriorates, well, they're in palliative care anyway, so no drama. What do you think of that as a sort of alternative strategy?
Yeah. Yeah, we were slightly uncomfortable about that. And yeah, it's a tricky one. I mean, if the person themselves is able to do shared decision making, I think that would be the obvious option, but often they're not. And I think that's where I feel uncomfortable. Should they be on anticoagulants if they're not able to do shared decision making? That's an interesting question as well. What I would say about this group is, if they get left and they're not conveyed, and somebody continues the anticoagulants and they deteriorate, and then they're brought in and there's a big bleed on a scan. It does feel quite tragic, and it's not just because the reason for conveying them to the emergency department is not because of neurosurgery. We know the neurosurgeons aren't going to touch them, but it is the safety of anticoagulation. But yeah, I think if there's a safe strategy of stopping the anticoagulant observing for 3 days, I'm not going to say I definitely endorse it, but I think that's probably an interesting one for the next NICE Head Injury Guideline. What I think,
Several questions around what's a head injury? Is a facial injury a head injury?
no,
And the other one is if someone's banging their head,
yeah,
that we see is that a head injury, and should
yes, it
that be
is.
just
Yeah,
go
it is. It
along?
is.
So
Yeah, yeah,
I think Mo and Rachel were interested in the head banging, and I think yes, you can give yourself a significant injury from
yes, yeah,
banging your own head.
yeah, yeah. It's
And
defined as any trauma to the head except a superficial injury to the face. So I think if
yeah,
somebody brushes past or catches their cheekbone on something and a small hematoma, we wouldn't call that a head injury. But
yeah,
yeah, and I think the other thing to bear in mind is that it's not always a direct trauma to the head. So in a high energy situation, it can be indirect as well. So that's
yeah.
that's another issue to bear in mind, that some of the people that you see, I remember doing the HITS-NS study, some of the patients with positive CT scans weren't necessarily suspected to have a head injury in the pre-hospital environment
Yeah.
because there were no external signs of injury. So, yeah.
We've also got are all antiplatelet agents the same? I think is the
No,
summary, particularly Tracy, Lisa, and others. You know, you've got aspirin, but actually there are more and more fancy antiplatelet agents that the cardiologists delight in using. And should we regard them as all the same?
yeah, no, they're not the same. And we have made the distinction in the recent NICE Head Injury Guidelines. So the ones with the greatest risk are prasugrel and clopidogrel. Aspirin has a much lower level of risk. So we wouldn't count aspirin as a significant antiplatelet therapy. So that wouldn't count as a blood thinner in terms of if you had loss of conscious amnesia and you were only on aspirin, you wouldn't need to do a CT scan. And similarly for shared decision making, if they were on aspirin, no loss of conscious amnesia, you wouldn't even need to do shared decision making. You could just not offer them a scan. So a significant lower level of risk from aspirin compared to clopidogrel and prasugrel. And in fact, the evidence that we were able to see in the NICE guideline was that clopidogrel and prasugrel carry the same level of risk as a DOAC, but all of them have a much lower level of risk than warfarin. Yeah.
So we've got one question here from Sarah, who is trying to tempt you into a pitfall, I think, by saying, which is the best speciality to look after head injured patients? Remember, this is being recorded.
Okay. Yeah, I mean, I think it depends on the stage of care that the patient's at. So I think the best group of doctors to look after patients with head injury in the emergency department are emergency physicians. I think if the scan is negative, but there are still concerns around intoxication or the patient being isolated, then they should be on an observation ward. And it's whoever has the doctors to look after them on their observation ward. I think ideally it should be an emergency department FY1 or FY2 who does the ward round with the consultant in the morning, and we review these patients, and that's what happens in Salford. But I'm aware of other hospitals where it's orthopedic surgery or general surgery where that happens. So I would say emergency medicine where there's where the scan has been negative. But obviously you need to have the beds and the doctors to look after those patients. And if you haven't got that in the emergency department, it will have to be one of the inpatient teams. But we haven't made a particular recommendation around that in NICE, other than if you look after the patient, you need to be appropriately trained, which is the same for all areas of medicine.
There's another interesting question here from Nuala, who's coming from some experience from falls from horses, and jockeys having a fit at the scene, but then recovering and being completely normal, on fairly rapidly after an arrival on in the ED. Whether she's noticed that those a couple of patients have been sent home without a scan, and we're just questioning whether
Yes.
you would scan those
Yes,
patients.
I would scan those patients.
I
I
would
think you
scan
would
those
scan those
patients
patients
too.
as well.
Yes.
Yeah. Yeah.
So yeah, I think Nudi, you're right to say that that's slightly unusual.
Yeah.
Interesting question here from as well from David, talking about we're talking about GCS measurement in a particular place, for example, on arrival in the emergency department. But
Mm.
given the really long pre-hospital delays we're now getting, does that mean that assessment is actually later than it was in the past? And should that change our thoughts about the pattern of change in GCS in any way?
Yeah, we did think about this in the NICE Head Injury Guideline because
Mm,
about 10% of head injury attendances present after 24 hours, but we decided that the indications for imaging and attendance are still the same. So yeah, if your GCS is impaired, you've got severe headache, you're vomiting, you still need to,
yeah.
to come to the emergency department. Yeah.
Another question about, you mentioned headache there. How do you tell the difference between a significant headache and just your head hurts because you've been banged on the head?
Yeah,
That's
I mean, you're interested to know that headache isn't an indication for CT particularly, but in the pre-hospital environment, we think it's tricky. Yeah, um, I think headache is quite a reasonable sign there has been some kind of traumatic brain injury, and even though I think on its own the likelihood of a significant brain injury is small, it can often I think predict post-concussional symptoms. So again, I would err on the side of caution. Um, yeah. I mean, if it was the only thing you saw in a head injured patient in the pre-hospital environment, there were no other worrying signs and they just had a slight headache, yeah, you could again use shared decision making and say, do you want to take a couple of paracetamol? And if it's still really bad, call us back and we'll come through or make your own way. But yeah, you would ask the patient, I mean, with usual pain scoring, the pain ladders in terms of the severity from 0 to 10. I'd say if it was a 10, you should probably convey the patient. If it was a 2 or 3, then yeah, not so worried.
a question from Tasha here, asking about the next set of guideline revisions, and rather than just do they have a positive scan as the endpoint, is there any thoughts of going on to a positive scan and something changed about the patient's management due to that scan as the endpoint rather than just being a scan positive?
Yeah, I mean, that's really interesting. And we've said obviously that if your scan's positive, you need to go to specialist neuroscience care if your GCS is 8 or less.
Mm,
We haven't ventured into the realms of what happens in specialist neuroscience care. There are brain trauma foundation guidelines for that. We have put a research question out around discharging people with small findings on the scan.
mm,
And then there is admission and observation guidance, which I haven't really covered in this talk due to time, but it does say if you've been admitted for observation, how frequent the observation should be. In terms of things that are likely to trigger the next head injury guideline revision, if we see some significant evidence around biomarkers, I think that's likely to trigger another revision because if brain's TBI suggests that biomarkers could significantly reduce the need for scans, then that would be revolutionary. And if point of care biomarkers suggest that you as paramedics can start to leave patients at home or leave patients in care homes safely, that could be revolutionary. So I think it's the brain injury biomarkers that are most likely to trigger the next NICE head injury scan. NICE head injury got scans on the brain. NICE head injury guideline.
Um, so many questions coming through. We're going to have to cut it in a minute. Perhaps do just a couple more. First thing, these late presentation, is there a time scale? If you have someone who's older, anticoagulated, but the head injury is 1 day, 2 day, 3 day, 4 day ago, is there a time when you'd actually say no CT scan?
No, not really, because again, this group as well are often at risk of chronic subdural hematomas.
Mm,
So I think if they're a head injury and they're anticoagulated, um, it just makes me slightly nervous. I mean, if there's no loss of conscious around amnesia and they're completely fit and well, like the example of the fit 75-year-old, then that's fine. But I think for an older, frail patient in a care home, yeah, because it's not just they're not going to get a neurosurgical operation, but it's around the safe continuation of their anticoagulants and the risk of a chronic subdural if there has been a small bleed. So yeah, I think it's worth considering. But again, it's got to be shared decision making with clinicians, the paramedics, the patient, and their family. And we are sensitive, or NICE is sensitive to advanced directives. So obviously, if this group doesn't want to come to hospital, then and they don't want to accept care and they have capacity to do that, then that's absolutely fine.
Perhaps again, do a last one looking for the future. When do you think that point of care testing for biomarkers might become available for pre-hospital use? What's your prediction of when that might be?
It depends on the findings of the ongoing research at the moment. So brains and pocket TBI are just getting going in about 14 emergency departments across the country. If they show that it's clinically and cost effective, and there is a pre-hospital study starting as well. So yeah, watch this space. It potentially is a very exciting development, not just for ruling out the need for CT scan, but we often struggle to make the diagnosis. I don't know if you do, Tim, of a traumatic brain injury in the emergency department because there's so many confounders. So yes, the person can't remember the injury, but they were intoxicated. So is the amnesia due to a brain injury, even if the scan's negative, or is it due to intoxication? Or in an older faller, is the amnesia just due to their dementia, or is it due to a brain injury? So I think biomarkers could be really helpful there as well.
Loads of questions about difficulties in evaluating the variable number, the variable characteristics of patients seen in pre-hospital care, particularly when there are other things that are clouding level of consciousness,
Yeah,
be it dementia, drugs, alcohol, and so
yeah,
forth.
yeah,
So a lot of
yeah.
cases
Don't
there
guess. Don't
which
guess whether
are
it's dementia or the brain injury or intoxication and brain injury. If they fulfil the guidance, bring them in. And I don't know about you, Tim, but you can't be criticised in that way for following the guidance about who needs to come to hospital. Or at least we don't criticise them in
No,
Salford.
no. I know there are, again, some comments about variability in ED consultants' approaches to this, and I think the bottom line is it isn't easy.
Yeah, it isn't
It
easy.
isn't easy, and there's often, there is still variation in practice there. Look, I think we ought to draw things to a close. That's excellent presentation. Thank you very much. I will just there do another plug here. Please become a trauma care member if you've enjoyed this. We put on this stuff for free, but it costs us to do it. It makes a difference if you join. A cup of coffee a month or a cup of coffee every fortnight is the cost. Please scan the QR code and join. Tom, can you go on to the next? No, I can do it. Yep. If you don't want to join us, we are very open to one-off donations. If everybody on the call tonight donated a fiver, that would make a huge difference to the charity and what we can do. Please scan the QR code and donate. We have a LinkedIn account now, so that you can follow what's going on, follow the various things that we've got planned over the coming year. And I think it just remains to say thank you very much to Fiona. Thank you to everyone out there, everyone that's joined us. I think we've had more than 700 people in the room. Please, everyone, stay safe, stay out of the wind tonight, and thank you very much for joining. And hopefully, see you in a month's time for the next trauma care webinar. Good night.
Thank you. Bye.